السلام عليكم ورحمة الله وبركاته. جمعة مباركة وعام وانتم بخير. It's a real pleasure having you all here today in one of the Saudi Heart Association webinars. Today it's an interesting topic, at least to me, and I hope for many of you, about heart failure, and will be sponsored by Servier. I'm Walid Al Habib, consultant heart failure cardiology and Al Habib Medical Group, and the president of the Saudi Heart Association. And with me, Dr. Khaldoon Al Hamoud, who's a consultant heart failure cardiologist and the director of an advanced heart failure and transplant program at Adan Hospital in Kuwait. It's a real pleasure having you today, and hope all the best and knowledge, inshallah.
Well, thank you very much for everybody coming. Thanks, Mr. Gay. Thanks, Dr. Walid Habib, for the kind introduction. It's, it's exciting to see a high number of participants joining. It's going to be, inshallah, Dr. Walid, my mentor. I don't want to make you old, but he's my mentor, and I always look up to him. And today we're all going to learn about updates on issues, heart failure management, and we're so excited to learn these.
Excellent. I will try to make my the microphone very close to my mouth, because apparently some of you are complaining against the voice. I think the voice is clear, Khaldoon, right? Is my voice clear?
For me, yes, loud and clear.
Yes, and Bilal, I think it is. So I'll start with my lecture. So update in heart failure management. It has been repeatedly said and well recognized that heart failure carries a very high morbidity and mortality, with at least 50% death within 5 years and 25% within 1 year of the diagnosis. This depends a lot on the stage of the disease, because we all know that the advanced stages, New York Heart Association class 3 and 4, have a 50% 1-year mortality. It also carries a high hospitalization and rehospitalization rate, with about 25% readmission within 1 month of discharge, which carries a big burden on the healthcare system and on the patient and family as well. We have also came to realize that patients who get rehospitalized, unfortunately, never come back to their normal stage. They just keep on deteriorating until they die, and each hospitalization carries an increased risk of mortality. So in summary, there's about 44% in hospital rate mortality. Our hearts registry was about 6% in hospital mortality. And that after a hospitalization, you get 30 to 50% mortality rate within 2 months, 60 days, and a 20 to 30% 1-year mortality after a hospitalization. That's why hospitalization has been a target of reduction in our treatments. I'm going to touch a little bit about the role of heart rate in the management of HFrEF in general, and Dr. Khaldoon will speak about practical ways of reducing that rate on. But we all know that elevated heart rate in cardiovascular disease, at least in ischemic heart disease, worsens ischemia and increases endothelial dysfunction and atherosclerosis, and worsens remodeling cardiac hypertrophy. And that was the main idea and focus that we've been taught during medical school all the time. But what we now recognized more and more, that even in heart failure as well, it worsens your ventricular efficiency, and of course reduces relaxation and increases the oxygen demand, even failure patients without ischemic heart disease. So even non-ischemic cardiomyopathies will get worsened heart failure with increased heart rate. And this has been proven by data that those with an elevated heart rate target 70 in heart failure patients have a significantly worse 1 year mortality and hospitalization. In several studies made us think that 70 is probably the magic or the cut point for patients with heart failure, um, uh, especially the non-ischemic heart failure patients, and has been repeatedly proven in many studies, comparing those with a lower heart rate versus higher heart rate. In one study, the 1 year mortality was increased by 41% when the heart rate was increased from 64 to above 80 in these patients. The HFrEF trial, which studied Ivabradine, proved the same concept as well, comparing those with heart rates of less than 70 versus those above 87, with a significant reduction in mortality and increased hospitalization. There was a 3% increase in combined cardiovascular death and or heart failure hospitalization for each 1 beats per minute increase. There was a 3% increase in the risk and a 16% increase with every 5 beats per minute. The paradigm as well, which studied the sacubitril valsartan, showed again very similar data that patients with a heart rate above 76 compared to those with less than 63 had a significant increase in cardiovascular death and heart failure hospitalizations as well. So how do we block or reduce heart rate? How do we work? The classic teaching was working on the sympathetic and parasympathetic tones. We work on the noradrenaline and block it with beta adrenergic receptors blockers, or acetylcholine for the vagal activity in parasympathetic. But recently, or not very recently, but more recently, relatively recent, we've shown that the HCN receptors, the hyperpolarized channels, which have the sodium current funny channels blocked by ivabradine, is another means of reducing heart rate as well. So beta blockers, which are the classic and the long-standing treatment that we have been using, are known to improve prognosis for with heart rate reduction proportionately to heart rate reduction, as we've shown in many studies. The lower your heart rate, the better, to a limit, of course. And it also significantly decreases mortality by other mechanisms, by reverse remodeling as well, and antagonizing the sympathetic system. A reduction in heart rate to reach values lower than 70 improves survival in patients with HFrEF treated with beta blockers. So it's not enough to target a dose in beta blocker use, but also a heart rate a target is very important as well. And it has been shown even with beta blockers, like I showed you in other studies with the ivabradine, that for every increase in 5 beats per minute, there was an 8% increase in cardiovascular death and a 16% increase in admissions to hospital. Unfortunately, and this is registry from the Optimized Heart Failure, one of the biggest heart failure registries from the US, showed that about 71% of patients on beta blockers discharged from the hospital still had a heart rate above 70 beats per minute, including 63% of patients discharged on 50% of target dose or greater. Of course, this is at discharge. You might be able to achieve the target dose later on when you follow the patient, but it's still worth looking at, knowing that sometimes you're not able to achieve the target dose or the target heart rate with optimal beta blockade. And again, back to the importance of this post-discharge period that we really focus on. We have showed you before and now in this study that all-cause mortality actually increases significantly in the first 1 month post-discharge. So it is a focus of treatment, and that's why many guidelines, and we do recommend that patients who have been hospitalized, especially if they are high risk, to be followed very soon after discharge discharge. It's not appropriate to give these patients follow-ups after 3 or 6 months from discharge. They should be seen within a week or two, a maximum 3 or 4 weeks to assess their risk. And again, rehospitalization is a big, big issue that we talk about all the time. The highest rate of death and up to 24% of hospitalization admissions occur during the first month after discharge. There are many reasons for this, and part of it is because we discharge patients prematurely sometimes. But again, even if these patients have been discharged in the right time, that hospitalization just increased their risk of mortality significantly. Now, when we talk about heart failure management in general, we have classically been talking about the sympathetic nervous system antagonization because of the sympathetic nervous system role in heart failure causing vasoconstriction. We antagonize that by beta blockers and sometimes alpha combined beta blockers, but mainly to relieve the vasoconstriction. We can use direct vasodilators as well. And the good thing about most of these adrenergics antagonizers, they will reduce heart rate as well and eventually lead to high contractility. We also antagonize the renin-angiotensin system because of its role, significant role in causing vasoconstriction as well. So when you relieve the after load, you improve the cardiac output and the and heart failure function. But as well as its effect on reversing remodeling of the heart. Aldosterone antagonists have been proven in several studies as well to improve mortality and morbidity in the RELS trial, EPHASIS, and EMPHASIS trials, and of course antagonize fibrosis as well. So for a long time, we have been classically using the beta receptor blockers and the renin-angiotensin aldosterone system blockers. Recently, we recognized the role of natriuretic peptides and neprilysin breaking these natriuretic peptides. As you all know, natriuretic peptides are a target of therapy right now, not just a diagnostic modality. Natriuretic peptides will cause natriuresis, but also vasodilation and reduction in fibrosis and aldosterone. So having a neprilysin inhibitor, which neprilysin, of course, breaks the natriuretic peptides. So inhibiting neprilysin and increasing the natriuretic peptides will improve the outcomes of these patients. And we all know the role of sacubitril combined with valsartan in the sacubitril/valsartan drug in reducing mortality and probably reversing remodeling as well. So these are the three main categories of classes that we have been using for heart failure management. But and all of them can actually help your heart rate reduction by improving your performance and your cardiac output. But nevertheless, as I showed you, many of these patients still cannot achieve the target heart rate we are looking for. The guidelines have clearly addressed these classes of drugs, all showing that any patient with a New York Heart Association class 1 to 4 reduced ejection fraction. So any patient with heart failure, symptomatic or asymptomatic, should be on an ACE or an ARB and a beta blocker to start with. That is the first line of therapy for all patients with reduced ejection fraction unless contraindicated otherwise. Next step, depending on the patient's symptoms and other factors, you would choose between the other classes, aldosterone antagonist, switching an ACE or an ARB to an ARNI, adding hydralazine nitrate, especially in African Americans, or of course CRT for those who have a wide QRS and are still symptomatic. And of course, in those who still have, as I showed you, a heart rate above 70, because heart rate is a target of therapy by itself, you should consider adding Ivabradine for these patients. Now, the difference between this is the American guidelines. The difference between this and the European guidelines. The European guidelines put it in a very clear stepwise manner. That if you start with ACE and a beta blocker, then still symptomatic, you add an MRA. If still symptomatic, you will and patient was on ACE or an ARB, you switch to an ARNI, and if the white QRS, you will consider CRT. But again, very clearly, if the heart rate is above 70, you should consider adding Ivabradine for that. Later on, if the patient is still symptomatic, and I need to stress on this very importantly, you have to consider advanced therapies, which is very important, and we miss it a lot that we stop here many times telling the patient there's nothing else to be done or palliative, which is valid in some patients, but many patients would require advanced therapy in the form of LVADs or heart transplantation, and should be considered in these patients. Our Saudi Heart Association guidelines have clearly stated it as well. We think that you should start ACE or ARB plus a beta blocker if still symptomatic to switch to an ARNI. Now, there's lots of discussion now, and I know many of you might raise this point, starting an ARNI for naive patients or even before ACE and ARB. It's a long discussion and controversial. Many might do it. Um, I personally still believe that ACE inhibitors and ARBs have a very good role in patients. Now, whether to start ARNI first or MRAs first, again, goes back to your experience and practice and your legislations. The European guidelines think that MRAs should come first, probably because of financial. We believe that ARNIs, because of the paradigm trial, not all patients were on MRAs. You could still start ARNIs before MRAs and up titrate to target doses. Always remember this. Target doses is crucial to get the best benefit out of these studies. If your heart rate is still above 70, and the patient is in sinus rhythm, remember that, because in AFib, it's not going to work. In sinus rhythm, then you should consider adding Ivabradine in these patients, just putting in mind that they are not in active ischemia. If they are in active ischemia, there is a higher there is a risk of using Ivabradine. But if there is no active ischemia, then the patients should tolerate Ivabradine quite well. Now, what is newer? As you all know, the SGLT2 inhibitors, the sodium glucose cotransporter 2, which is in the proximal tubule, usually reabsorbs glucose and sodium, but these receptor blockers, namely dapagliflozin, empagliflozin, and canagliflozin, block this receptor and reduces the reabsorption of sodium and glucose, causing more diuresis, natriuresis, and vasodilation. And it has been shown that these SGLT2 receptors are even available in the heart. So we're not really sure how it works on the receptors in the heart, but apparently it does have a very strong effect that was proven in the dapagliflozin DAPA-HF trial, where they studied this drug in patients with reduced ejection fraction, whether they had or did not have diabetes. And this question was very important because more than half of these patients did not have diabetes, just had reduced ejection fraction. And as we know, it reduced the composite endpoint of death, heart failure hospitalization, or urgent heart failure visit by 26%. It reduced the incidence of worsening heart failure and cardiovascular death significantly with a significant p-value. And as I said, it didn't matter whether these patients were diabetic or non-diabetic. Interestingly, a recent sub-analysis which has been published a few days ago, that those on dapagliflozin even had a lower incidence of developing new onset diabetes when they were on dapagliflozin. So it might be even a protective drug, especially in pre-diabetic patients, if in patients who are on dapagliflozin. So cardiovascular death or heart failure hospitalization was reduced, and the in incidence of first and repeated hospitalization. So reduction in first and repeat hospitalization was also significantly reduced. All-cause death, as well as you can see here, was reduced by 17% in these patients. So, and it just recently got the FDA approval for use in heart failure, yeah, experience with it is quite good as well. The newest kid on the block, very Segwat. As you all know, that nitric oxide works on the cyclic guanylyl cyclase, soluble guanylyl cyclase receptor, the increasing cyclic GMP. And cyclic GMP has been shown to help in vasodilation, improve vascular dysfunction and myocardial dysfunction. It works on the heart, on the vessels. Although nitric oxide hasn't been used in heart failure, mostly because it's gaseous, but we use it in pulmonary hypertension as well. We also used these direct stimulators of guanylyl cyclase in pulmonary hypertension, but now very Segwat, independent of nitric oxide, has nothing to do with the nitric oxide, directly stimulates the soluble guanylyl cyclase receptor, increasing the cyclic GMP and improving the function. And the newest trial, the Victoria trial, which was published in New England Journal of Medicine, had shown a significant reduction in the primary composite endpoint of cardiovascular death or heart failure hospitalization. But as we all know, this was mainly driven by hospitalization for heart failure and the combination of death or hospitalization for heart failure. There was no significant reduction in cardiovascular death alone. It was mainly heart failure hospitalization, the main drive of this outcome. So this is the newest on the block. Of course, now we have other medications in the pipeline as well. We are expecting soon a publication of the galactic heart failure omecamtiv mecarbil as well, is going to be published soon. So I'm very happy that right now, as heart failure specialists, we have a lot of options to help the patients, and I'm pretty sure that each patient will have a profile that benefits from one or the other, or even the combination of many of these drugs. It's very nice to have added medications that can still help these patients who have a high mortality. Nevertheless, I would like to insist on the importance of two main factors, which is the importance of very close follow-ups and monitoring of these patients for the best outcome, as well as reaching the target doses, as well as compliance of patients through these target doses to get the best outcome. Thank you very much. Now we will move. I will leave the questions to the end, so we can look at both discussions. Dr. Khaldoon now will talk about heart rate control in patients with heart failure, a practical approach. Let me unshare the screen. Is my screen still shared, Ya Khaldoon?
No, it's out.
Okay, good.
Okay, thank you very much, Dr. Senver, for this very elegant review and overlook on the future. So I will, without further ado, I will start slides. Can you see them now? Is it shared? Oh, okay.
Yes.
So the way I'm just sort of really paved the way nicely for me to present this practical clinic or clinical approach on how to attain to that goal of rate. My name is Dr. Khaldoon Mahmoud. I'm heart failure cardiologist from Kuwait. So now our agenda is going to be the following. We're going to talk about heart failure with reduced ejection fraction versus heart failure with preserved ejection fraction. Are they the same? Do they behave the same? Do we act towards them the same way? We're going to talk about the beta blockers and how to approach heart rate control, and Ivabradine, how to use it appropriately, and some real case review to set an example, and finally a take-home message. Now, in HFrEF, as we know from our basic equation, to achieve a proper heart cardiac output, what we want to do, we want to increase our stroke, or increase our heart rate. It's the product of the two. Reducing the heart rate is beneficial for the heart in general, as we know, increasing, which would cause decreased volume and increase diastolic. So heart rate control is important in management of HFrEF patients. We aim for a heart rate less than 70. The strategy is to increase the filling time, which may also lead to increased cardiac output, as well as reducing the cardiac oxygen demand. Atrial fibrillation patients should be considered for either rhythm or rate control, because atrial fibrillation is quite determinant and affects their cardiac output.
Khaldoon, sorry to interrupt you. Can you make the mic closer to your mouth, please? Just for the
okay. So I thought my voice was good, but
it's good, but can be better.
Okay. Now, how is it now? Is it better? Can you hear me better now? Let's see.
Yes, it's better. It's better.
Okay.
Yes.
So in HFpEF, I just want to put a small slide on this just to make clear. When we talk about heart failure patients, we should be really careful about each group. In HFpEF, those patients, and I will give an analogy, they are actually, they cannot really manipulate and increase their end diastolic volume much. So they're quite restricted then. So those patients require usually higher heart rates, not tachycardic, but something above the range of 70, going to 50s and 60s, it really makes them, uneasy. There is limited or no benefit from filling time increase due to the small restricted ventricle, and the increase of heart rate is a useful mechanism to increase their cardiac output. In those patients, atrial fibrillation actually is really worsen their condition if you are able to revert their AF, or at least control it, because the atrial kick adds a reasonable amount of their cardiac output and functionality. And you notice patients, if you manage to revert their AF and they go back to sinus, immediately feel quite better. Now, my water bucket analogy goes like this. I tell my patients actually why I need to reduce your heart rate and why do I need to increase your filling time. I tell them I have 1 minute here to fill up 5 liters. Let's say the heart is going to go with a cardiac output of 4 or 5. So this, within 1 minute, the heart should pump out 5 liters. Now, if I have, in cases of HFrEF, for instance, a small bucket here, if I give a little bit of more filling time, then maybe within this 1 minute, that weak heart was not able to do a 5 liters in 1 minute. But maybe if I increase the size of my end diastolic volume, then I would be able to achieve a good amount within 5 minutes. But if I am restricted, so increase the volume. But if I'm restricted in a tiny cup, which is this tiny restricted ventricle, going very slow actually is not going to help me. It's going to worsen my ability to pump out those 5 liters in a minute. So maybe a little bit of speed would help me. So that's why when we talk about Ivabradine and concentrating on heart rate control, we talk about HFrEF patients and not much about HFpEF. HFpEF should be dealt separately. I just want to make the pathophysiology quite clear to everybody. Now, let's concentrate on the core of the topic, is how to reduce heart rate in HFrEF. So HFrEF is, we define it when we have a low EF of less than 40 or less than 35. In some definitions, first line medical therapy, number one is beta blockers. We use beta blockers not aiming basically for heart rate control. What we do, we actually we need it for damping our sympathetic overdrive, which an addition effect is reducing heart rate, which is also a beneficial. The second line of therapy would be Ivabradine, only in sinus rhythm patients, and I'll go with that. But in atrial fibrillation, heart rate may be controlled with digoxin as an additional therapy on top of beta blocker. It is known without saying that calcium channel blocker, mainly the undihydropyridine calcium channel blocker, which are used as antiarrhythmic, are absolutely contraindicated in heart failure therapy. So do not aim for heart rate control with calcium channel blocker. This is an basic information. So let's talk about beta blockers. Beta blockers are recommendation 1A in all the guidelines, in addition to the ACE and when the patient is stable. The evidence-based medicine beta blocker useful in heart failure are namely 3 beta blockers. They are the carvedilol, metoprolol, and bisoprolol. So we always start with a very minimal dose. The minimal dose we can use, like in 3.125 for carvedilol, metoprolol, succinate, or tartrate. We start with a very low dose, and the bisoprolol 1.25. In all the guidelines, we see metoprolol. Succinate is always one to use, the XL form, but in reality, in so many countries, seen in Canada and other countries. I mean, and when I discuss with many experts, when it comes to metoprolol, I think metoprolol is metoprolol, and if you don't have succinate, tartrate would be a reasonable option, just as good as succinate. We start with the lowest dose possible, and we slowly up titrate over 2 to 4 weeks to reach maximum tolerable dose. You know, and we maintain the heart rate to be between, you know, less 60 to 70. Try your best to do that. And a systolic blood pressure above 90. And you ask about being symptomatic or not. So the patient, if the patient can tolerate a nice 90, 95, and not being dizzy, I will keep the dose as it is, and I really need to be symptom guided as well as blood pressure guided and heart rate guided. So once I reach my target, I stop. Once I have room and I have good blood pressure, I keep going on. And the patient should realize that he is getting a minimal dose. I tell my patients, I'm going to give you 10% of the dose. Let's wait, and I'm going to give you another 20% or 25%, 50%, and until I reach your 100% dose. So a patient should realize that he is in a journey of up titration, that will help you a lot. I tell my patients that usually when you initiate the therapy or up titrate it, you might feel an unpleasant symptom, just feeling a little bit crummy. It would subside in 4 to 5 days because of the initial negative inotropy. So patients should realize and be prepared that they might not feel comfortable with initiation or up titration, because they might stop it. I mean, you might give them and you might up titrate, the patient goes home, take his increased dose, and then he goes back to his old dose without consulting you, said doctor, and then you see him after 2 months and he says, are you on your up titrated dose? And no, doctor, I stopped it. I went back to my previous dose because, you know, once I took it, I felt bad. So he said, yeah, so you lost already a period that you had been. So the good thing is to tell a patient, uh, tell him, most likely you're not going to feel anything, but in case you feel a little bit crummy, uneasy, and your blood pressure is fine, there's no pre-syncopes or whatever, just continue on the dose. It will fade away in 4 to 5 days. There is some special consideration that do not initiate it in acute decompensated heart failure. In the acute state, beta blocker should not be initiated. If they are on beta blocker, some people in cardiogenic shock, it would be stopped. In decompensated, people might stop it or a minimal dose. It depends on the situation, but it is not for an acute setting. Do not aim for rate control at acute decompensation or cardiogenic shock. You start when the patient is not volume overloaded. Okay? When they are coming to you, volume overloaded, lower limb edema, very high JVP with beta blockers, just going to make them even worse. So try to aim to unload your patient first, and then once they are dry, lying flat, that's when you start initiating small doses. Be careful with heart blocks, okay? Especially if, of course, they are without pacemakers. If a patient has a pacemaker, well to go, but those with second and third degree heart block, you should really be careful in starting beta blockers. They should be given with anti-RAS therapy, okay? With ACE inhibitors, ARBs, or RNAs, but there is no actual preference exactly on when to start. People depends, on the situation. Ischemic patients, maybe you would go more with beta blocker, and then second, third day you start that. They could go hand in hand. Again, if the patient's blood pressure is really high and they would tolerate. History of beta bronchial asthma and COPD are not absolute contraindication for beta blocker. It is very saddening and heartening to see a patient that was denied therapy with beta blocker just because he had a history of being asthmatic or being COPD or took a nebulizer once in a blue moon. Though many of our patients are also on having bronchial asthma, they are on beta agonists, they are on other medication for their asthma. In the same time, they are also on good doses of beta blocker, unless if they do not have um, reversible, active airways and wheezing with beta blocker. Maybe sometimes they will not tolerate a 10 milligrams of isoprolol, but they might tolerate a 2.5 or a 5. So if they can tolerate a lower dose, do not, deny them of beta blockade benefit just because of some bronchial asthma that is easy control. There are some troubleshooting bradycardia. So if a patient develops bradycardia with beta blocker, there are things to do. Check, is he on a dihydropyridine calcium channel blocker? Is he on digoxin? Does he really need that digoxin? Is there Ivabradine on top of your beta blocker? Maybe you would step down and go a little bit up on your beta blocker. If there is, if severe, maybe the patient needs a pacemaker. It's a conductive issue. Another problem you would face with beta blocker is hypotension. It could be symptomatic or asymptomatic. If it's symptomatic, look at other antihypertensive agents such as other vasodilators, alpha blockers, even prostate medication could be a cause. If he's on other lodipine or other diseases, other antihypertensive medication, maybe you really don't need them and you should concentrate on your beta blockers. Assess the need for reduced or stop diuretics. I mean, maybe the patient is hypovolemic and he's taking unnecessarily a lot of doses of diuretics. Assess the diuretic needs and try your best always to reduce it every visit based on your volume status. Hypotension, which is asymptomatic, you may do nothing, resume the medication, reassure him, and keep, because the problem, they would go They would be happy with a 95, doing very well. And the moment they enter a GP and a doctor tells them, oh my goodness, your blood pressure is 90, stop that, because why are you taking an antihypertensive when your blood pressure is 95? And that's really a problem. And then he stops with beta blocker. So you have to tell them that if your blood pressure is 95 and you're totally asymptomatic, no dizziness, no postural hypotension, just keep on doing that. The other problem is worsening of congestions, and their NYHA worsen, and they are having to show signs of edema. Again, you have to increase your diuretics, dry them out, see what happens. If all the above fail, consider reducing your beta blocker by 50%. Rarely you need to stop, and really consider and ask yourself 1,000 times before taking that decision of banning beta blocker on a patient. We move to Ivabradine. It has been introduced in the HFrEF trial back in 2010. It's a multi-center randomized double-blind placebo-controlled parallel trial, a one-to-one Ivabradine versus placebo with around over 6,500 patients. It was a multi-center, 677 centers over 37 countries. The median follow-up was around 23 months, and the primary outcome was heart failure, death, and hospitalization. It was significant. The study was positive. It made its way in the 2012 and 2016 guidelines, and it was given a recommendation 2A for heart failure, EF less than 35% with a heart rate more than 70, while a patient, despite being on beta blocker, ACE, and AR. So from the statistics, it showed a very significant p-values and relative risk reduction of when it comes to hospitalization and heart failure, and whether it's on hospital admission for worsening, worsening, the primary composite, and death and worsening. And when it came to death from heart failure, it was also significant, but it was not significant when it came to cardiovascular alone death. And when it was reviewed, the drug was actually given in a placebo and Ivabradine were very well paired. And you can see many patients at that study reached all 90s and upper 80s in percent of beta blocker, ACE inhibitors, and diuretics. Ivabradine, as has been explained, slows the heart rate while inhibiting the IF channel or 20 channel at the SA node level, only for patients with sinus rhythm, because the site of mechanism is the atrial node, so it is not a drug to be given to someone with atrial fibrillation. There is related reduced mortality and hospitalization in those patients. It has no effect on blood pressure, so it's quite safe with those with BP. Once you reach your threshold in blood pressure and you cannot go more on beta blocker, Ivabradine would be an excellent choice. Given on top of beta blocker with a maximum tolerable dose, as we have explained previously, with anti-RAS therapy, ACE, ARB, or ARNI, and mRNA, it is not a substitute to beta blocker. So please do not view Ivabradine as a substitute, or it is this or that. It's always beta blocker, and this is an add-on therapy, and rarely, and it's only a substitute when beta blocker is absolutely you're absolutely unable to add it on the patient. So how to initiate the therapy? We start with a low dose first, 5 milligrams, 12 hourly, and you stop at 7.5 milligrams, 12 hourly. In elderly patients above 70, you may start with a dose of a 2.5 twice a day and see how it goes. Do not go with up titration faster than twice every Q2 weekly. So give them always 2 to 4 weeks to up titrate. Again, it is for EF less than 35, heart rate more than 70, NYHA 2 to 4, and should be on ACE, beta blocker, and MRI. I cannot insist on that more. There are special considerations. You do not give it in an atrial fibrillation patient. You do not give it in acute settings, such as acute coronary syndrome, acute decompensated heart failure, patients in shock, or acute neurological injury like CVA or TIA, and severe renal dysfunction with a GFR less than 15. So somebody with a mild or moderate renal impairment can receive it. Severe liver dysfunction. Pregnancy and breastfeeding has not been studied, so don't attempt it for pregnant ladies who want to control their rate. We have a safe beta blocker is quite safe in pregnancy if really needed. Patients with a heart rate of less than 50 beats per minute at rest, you really should not give beta blocker. There's no Ivabradine, there is no point for that. There is some drug interaction with antifungal and macrolides. Doctors should be aware about that. So some troubleshooting, what happens if they develop AF? Well, if they're an AFib, you can stop it abruptly. There is no rebound mechanism or anything. It is safe to stop. If they go into cardiogenic shock, for instance, you just stop it abruptly. If the heart rate is less than 50 beats per minute at rest, you may consider other causes. Well, is he going into heart block? Is the patient having other diseases that cause bradycardia, such as hypothyroidism? That's why we always do annual or biannual check on especially those patients. They could be on, for instance, received amiodarone, heart failure, and AF. Well, you never know. So you have to be more open-minded and look for other causes. They may develop some GI symptoms if they have lactose or galactose intolerance, because it's one of the components of the tablet. So don't be surprised if after you start to have Ivabradine, they have these symptoms such as lactose intolerance. Some patients to some degree might stop the medication based on that. Very interesting. I've seen it once in one of my patients who I need to stop it. It's a luminous phenomenon known as phosphine. In the trial, it came in 3% of the patient versus 1% in placebo. Number is it's not really high, but again, it is significantly positive. So what phosphine is a phenomenon described as whether either be a transient brightness in limited areas of visual field, halos around things, image decomposition, like stroboscopic effect. That's what my patients said. I move my hand, I see it like going in a jerky movement, color bright lights, and multiple images sometimes. They move their eye and image stays there. It has effect directly on the retina. So the onset usually in the first 2 months of treatment. It's mild to moderate intensity. Discontinuation is quite low, and most of them just resolve. My patient just disappeared after stopping Ivabradine. But it's not a very common phenomenon that you might encounter, and it's not very dangerous. So in the guidelines, this image has been presented by Dr. Waleed. In the guideline, it is the European guideline, which I really find it very clear. In HFrEF patients, again, we start with AC inhibitor and beta blockers. With those with AF less than 35, and still symptomatic, you will give them MRI. So we reached our 3 medications that we know that they are 1A recommendation. If they are still symptomatic at that stage, there are 3 scenarios. Either shift them from ARB to ARNI or ACE to ARNI, add a CRT for those wide QRSs, or if it's clearly mentioned that if they are still tachy, bring down their heart rate below 70 and see how they respond to that. If all that persists, there are other medications they might need digoxin or hydralazine nitrates, or advanced therapy like mechanical support, LVAD, or a heart transplantation, or maybe they will only require palliative treatment. But here, as you see, throughout the course of therapy, diuretics is only for relieving symptoms and signs of congestion. It can be given all over therapy, and you try your best to get them off as much as you can. And in all and throughout the therapy momentum here, ICD is always an option, either a primary or a secondary prevention. I conclude the talk, and I will go with a clinical case scenario. This is the patient, Mr. N, 50-year-old. Now we've been following him since first visit was 2015. It's a case of ischemic cardiomyopathy, low EF. He had a massive anterior wall MI, and he had PCI, multiple PCIs, and at that time he did an intra-aortic balloon. So you can realize how turbulent his course was. He has an ICD on him. His EF was 30 to 40, and his as you say, his QRS was not was around 88. He was, by time medication has been going up and down and juggling around. He ended up being on valsartan, spironolactone, bisoprolol, furosemide, and metformin. His vitals on a visit in 2017, his blood pressure was 90 over 70, heart rate was still 98, and NYHA2. Ivabradine was introduced at 5 milligrams and up-titrated 7.5. This is the last visit we saw him in the clinic in 2020. And I'm trying to put these snapshots and images from the file just to make it actually very authentic, and we see how we are dealing with a real person. With time, we noticed that his EF, he had quite a remodeling, and the EF went up to 45. His diastolic grade 1, his function normal RV, the IVC is not dilated. BP went up quite higher, for 100 over 60. Heart rate was at 70. Generally, his HABP clinically was not dilated. He had no lower limb edema, and he was NYHA, no shortness of breath, no PND, no orthopnea, and no syncope or dizziness. The patient was euvolemic on clinical examination. Kidney functions were fine, and we tried to up-titrate his ARBs, but his BP was soft. He cannot really, so we stopped at where we are. But again, we added for him in that visit the pegliflozin, 10 mg per day, and he was on only 20 milligrams of diuretics. We ended up stopping them. So what I learned from this case is that patient was up-titrated on his anti-failure therapy to maximum tolerable doses, and he had a soft blood pressure, still remained with an NYHA of 2. And after adding and up-titrating ivabradine, his heart failure symptoms improved to NYHA1, heart rate maintained at 70, with improvement in his LV EF to 48 with no diastolic dysfunction. And notably, the last anti-proBNP came as 92. Systolic remained around 100, and will consider up-titrating maybe if he tolerates his ARB, or because there's no point of shifting him now to an ARNI since he's NYHA1 and his EF is 48. So my take-home message would be that heart rate control is an important strategy in treating HFrEF patients. A heart rate below 70 beats per minute is associated with improvement of survival, hospitalization, quality of life, and cardiac remodeling. If the heart rate target is not reached at maximum tolerable dose of beta blocker, considering adding ivabradine as a recommendation level 2A, and Ivabradine should not be initiated in acute states or in atrial fibrillation patients. Thank you very much, and I conclude my talk.
Thank you very much, Khaldoon. It was a very nice review and practical. You thought that was short, mashallah. What what would be long then?
يوم جمعة يلا
Yeah.
قلنا ناخذ راحتنا شوي.
Yeah. So we have mashallah lots and lots of questions. And I know the time is quite up, so but we will take a few maybe for 5 minutes. There was one question about the target heart rate. When is it taken at minimal exertion? No, it should be. This is the resting heart rate. This is what we talk about all the time: resting heart rate. And the resting heart rate is best taken when the patient wakes up. But if the patient comes to your clinic, the patient has to rest for at least 5 minutes, and then you take the blood pressure and heart rate, and that's the one you base on. Make sure it's not the heart rate on exertion. Another question is, how do you choose beta blockers? I have some disagreement with Dr. Khaldoon on his choice of metoprolol tartrate. The approved metoprolol in heart failure is the succinate.
Succinate, yes.
Yeah, is the long acting.
We don't have it in Kuwait.
Yeah.
No succinate in Kuwait.
Unfortunately, it's not available.
Even in Canada. Even in Canada, it's not available.
Even Saudi Arabia. Yeah, even Saudi Arabia. So we in that case, we prefer either carvedilol or bisoprolol. How do you make the choice? If the patient has any history of asthma, you probably want more beta-1 selective versus non-selective. Bisoprolol and metoprolol succinate have the advantage of being once daily. We don't have the carvedilol once daily, although it is available in the States as Coreg once daily that you can use. But these three are interchangeable. They can be used with no preference which one to start with. It depends on your experience. Now, there's a question about heart transplantation and VADS. I think this is not the topic of today. It's a long question, but it's an important one that should be addressed at some point. Now, not even heart failure with normal EF and minimal symptoms. Now that takes me to your case, Ya Khaldoon. Your patient's heart ejection fraction was already 45. Was he indicated for Ivabradine?
Initially it was 35. No, it was 35.
35 when you started.
It went.
Okay.
No, yeah, when it improved actually to 45.
So this is very important to notice that the ejection fraction by study and guideline has to be less than 35 when we use it. Now, someone was asking if the patient develops atrial fibrillation on Ivabradine, what to do? Definitely to stop it. Definitely to stop it. Would you switch? This is a question, Ya Khaldoon. Would you switch metoprolol to Ivabradine? And you stated that clearly, but you can probably remind them, when would you change? It's usually an add-on, but when would you change a beta blocker to Ivabradine?
Okay, so just answering this question, you really have to have a very compelling reason not to give beta blocker. Just having a history of even as you know, let's say COPD is not absolutely a contraindication in. It's actually beneficial in COPD, and there are studies that show that beta blocker in COPD reduce hospitalization, because the physiology, the pathology of what happens in a bronchiole in a COPD patient is different than what happened in an asthma patient. They both wheeze for different reasons. It's very important because our patients with cardiovascular disease, they're smoker. It would be another confounder, another disease that come hand in hand with heart disease, which is COPD. So it's very important to know that some of them are having reactive airways, and some of them are just chronic thickening and mucus plugs and all that. So Do not deny them just because they had a history. And when we come to the asthma patients, those with hyperactive airways, you have to be cautious and careful. But you have to give them the chance. If he can tolerate a small dose of beta blocker while he's on anti-failure therapy, continue doing that. In a very minority of patients, where even a tiny dose of beta blocker causes them to be hyperactive and cannot tolerate even a 1.25 carvedilol, bisoprolol, then you would tell him, well, you were given the chance. I'm sorry, you cannot tolerate it. Maybe you would give him Ivabradine just to help them reduce their heart rate. But using it as a direct substitute is not justified. Another point where Dr. Wali talked about choosing between. Of course, I jump between beta blockers depend. For instance, carvedilol has a lot of alpha blockade. I love carvedilol. Once I'm having a problem of blood pressure control and it's really quite soft, I see them. I shift to carvedilol to Concor or Zoprolol, which would give me the heart rate the control that I need with less effect on beta blocker. Moving between beta blocker is very valid, dependent on each case and your experience. As Dr. Waleed said, I'm just echoing what he said. And do not think that Ivabradine is one of those drugs that you just jump from one to the other. Beta blockers are beta blockers, and Ivabradine is Ivabradine. Be very, very justified on when you switch.
Excellent. One question here, a patient very similar, quite similar. He had cabbage, ejection fraction 25%. They started metoprolol and they went up to 100 BID. Again, I do not recommend metoprolol at heart rate for such patients, but the heart rate was still 90 beats per minute. And of course, the second option is to add Ivabradine. And yes, he's asking, do we combine it with metoprolol? Yes, it is on top of beta blockers. You do not stop the beta blockers. It should be together. Now, a lot of questions about ARNI and dapagliflozin right now, having both of them. There are as many. Would you start ARNI first or DAPA first? This is still up in the sky. I think it's going to come to the experience and practice of each one of us. The patient profile might indicate it. If your patient's blood pressure is on the lower side, if the ejection fraction GFR is low, I might go with dapagliflozin first. If the patient is diabetic, I might go with DAPA first. But again, there is still strong evidence with ARNI, and most of us would still start ARNI first before adding the dapagliflozin. In many cases, and that's probably advertised or promoted by many authorities, is probably think of starting them both. These patients are symptomatic. They would benefit from starting both, one after the other. And there is evidence that the combination would probably gain better outcomes than a single one of them than the other. I know there are lots of questions, but I think we're running out of time. Khaldoon, any final words?
Well, there is this question I find it surprising. Low dose aspirin role in heart failure. So there is no role for aspirin unless there is a coronary artery disease. And if the cardioselective beta blockers are safe in asthma, they are beta blockers are beta blockers.
But safer than the non-selective, of course.
Safer, but they will
at higher doses. At higher doses, they might.
If he's prone to have hyperreversibility, they will. But you have to always be cautious and don't give them as assuming nothing will happen. As you said, there's lots of interesting questions.
Just out of time.
We're out of time.
Yeah, out of time. Again, thank you very much, Dr. Khaldoon. Thank you, Sylvia, for sponsoring this. Thank you all attendees for participating and discussing. There's this question all the time about how do I get my certificate? How do I get my CME hours? Just communicate with the SHA. as you registered, and you can always follow the SHA account at Saudi Heart on Twitter to get all the updates about the webinars and the activities of the Saudi Heart Association. Again, thank you very much for all being here, and hope to see you in future events.
Thank you very much. Thanks a lot.
Thank you very much.